Welcome to the What, Why, and How of Weight Inclusive Care. This will be an introductory lecture discussing the research surrounding weight inclusive care, why it matters, and how we start to include it in practice. Let's take a quick moment for disclosures. I have no financial disclosures. No one is paying me to be here or do this, but I would like to take a moment to discuss some of my identity and how that has shaped my worldview. I am a cis, hetero, Chinese female who is able-bodied and also has thin privilege, which I will discuss later. And I disclose these because we are all intersectional human beings with not just one identity. And many of these provide us with opportunities, neutral experiences as we exist and navigate the world, and may also subject us to more marginalization or oppression. And just as you have intersecting identities, I think it is important to investigate these and also know that these have shaped much of our lived experience. And a quick content warning, I will be using the terms fat, overweight, and obesity epidemic because this is how the context of this shows up in the research. But I also want to note that they are inherently stigmatizing because they equate weight with health and also size with health. And the term obesity itself comes from the word obesis, which means to eat oneself fat, which is inherently wrong. We have always had different sizes and shapes of bodies since the beginning of time. And our current definition of obesity is based on the fallacy of BMI, which we will dive into more deeply during this session. And my invitation for you is that this conversation is likely going to be somewhat uncomfortable. And this conversation is not to be judgmental towards you as a practitioner or individual, but as an invitation to get curious about our roles as clinician and the systems that we are participating in. It is important to note that every single body has the right to bodily autonomy, and your definition of health is going to be very different from every single person's definition of health who ends up walking into your office. And so if you start to get uncomfortable during this conversation or start to notice that there's some hesitation coming up, I really invite you to ask yourself, why might I be responding in this way to this information? And what beliefs, norms, or biases might I have that are resulting in this feeling? Quick overview of the content. We are going to start to gain a better understanding of weight bias, anti-fat bias, stigma, and discrimination in overall society as well as healthcare and how this impacts healthcare and people's relationship to health and disease. We will also investigate the role that diet and wellness culture and thin privilege play in perpetuating shame, stigma, and discrimination. And we will hopefully begin to understand the difference between a weight centric versus a weight inclusive or neutral approach to healthcare. And we will start to understand how to address our own biases within clinical practice and start to shift into a more neutral approach to care. Let's do a quick overview of just the definition of terms that we will be investigating today, especially when it comes to bias and stigma. And so weight bias describes kind of the thought processes that impact our behaviors. I like to think of this as basically a one-on-one aspect. So basically, it is the negative attitudes and beliefs towards someone about other people because of their weight and size. When we look at weight stigma, it is the negative societal perceptions, assumptions, and stereotypes and judgments experienced by those who exist in larger bodies or fat bodies. And this term weight stigma inherently implies shame and perpetuates the systemic oppression of a specific group of people, specifically in this case, fat people or bodies of size. This is not a preferred term that is used by much of the fat community because it is inherently attached to shame and it perpetuates a stigma, but you will start to see it in research, academic settings, and academic settings. And I like to think of this as basically an individual experiencing bias from a much larger system. Then we have internalized weight stigma. And so it is holding self-directed negative beliefs based on societal stereotypes about their own weight or size. This has a distinct and direct correlation with health outcomes, independent of someone's BMI, their overall size, or the weight on the scale. And I like to think of this as basically an individual versus themselves. And anyone across the size spectrum can, no matter their size, can experience this internalized weight stigma. And if someone experiences this, it is directly related to lower body satisfaction scores, decreased motivation, and also negatively impacts health markers. Weight-based discrimination is the inequitable treatment and or impact of systemic policies and practices and norms on individuals. I like to think of this one as well as like individual versus a much larger system. And the term anti-fat bias is the attitudes, beliefs, and societal systems that specifically marginalize and exclude and underserve people in certain fat bodies or bodies of size. So this is a term that kind of encompasses all of it when it comes to weight bias, stigma, internalized weight stigma, and discrimination. And this is a term that is often used by fat communities or preferred by those who exist in fat bodies because it doesn't have the term stigma attached to it, and it's understanding that there is an inherent bias against this, just like racial bias exists. And since 2021, we've seen an increase in the discussion of destigmatizing BMI and weight from obesity medicine practitioners and weight management providers. And while this seems benign and maybe even progressive, what this is truly doing is that it is categorizing someone's body size as a specific disease or disease state. And what they are starting to do is co-opt a lot of this language saying, hey, it's not your fault. And now we have these great pharmaceutical drugs to shrink your body in order to fit the norms that also fit within this BMI curve. So I mentioned thin privilege. I want to just discuss that for a moment. And thin privilege is something that impacts everyone. And anti-fat bias harms everyone. And so thin privilege is, or privilege in general, is when you think something isn't a problem because it doesn't directly affect you. And so what this means is that your everyday life hasn't been more difficult because of the size of your body. So if you don't ever have to think about finding a comfortable seat in an airplane or in a restaurant, or have to worry about finding clothes at Target or a local department store, then that means you likely have thin privilege. And thin privilege does not mean that you've never had body image issues, that you feel thin, that you are thin, or that you've never struggled with disordered eating, or you've never been bullied or shamed for your size, or that you like your body. And it doesn't mean that you haven't experienced discrimination in other areas, as in your ethnicity, gender, sexuality, class, or etc. And thin privilege grants you access to respectful care, higher wages, seating, clothing, perceived physical ability, acceptance and fitness in outdoor spaces, as well as autonomy around food choices, and accurate portrayal in the media. So recently, if you've watched Inside Out or even Inside Out 2, we see this pretty prevalent in there where some of the less desired emotions such as sadness or embarrassment, those are portrayed in characters who are in fat bodies. And we also see this a lot in even Disney representation. Typically, any sort of villain or any sort of bad character in those films are also likely portrayed in fat bodies. So we can start to understand that this anti-fat bias is so prevalent and it exists all around us all of the time. And it harms us in all bodies because what happens is that it increases the overall fear of gaining weight because people know that this bias exists and people know that marginalization and oppression exists for people who are existing in larger fat bodies. So this also perpetuates yo-yo dieting, shame around bodies, and this extreme desire for thinness. Because of that, it's also going to perpetuate disordered eating and eating disorders, and it's also going to decrease access to care and provide more biased care to those who are in thin bodies. So we'll talk about that as well. Let's take a moment to discuss bias, specifically implicit, explicit, and also anecdotal or confirmation bias. So, explicit bias are the intentional and deliberate and conscious attitudes that influence an outward behavior or action in a direct manner. So, an example of this would be a fat patient coming to their doctor for hip pain and instead is told to lose weight. So, what this does is this will undermine their overall trust for that provider and also undermine their trust for providers in general. The reason why is because this individual came in asking for help for their hip, but their doctor instead decided to go down the pathway and the rabbit hole of, well, you need to lose weight. So what's happening is they're being shamed for their body, they're getting biased care, and they're not actually getting their primary concern addressed. Then when we start to move into implicit bias, these are the unconscious and automatically activated biases due to societal norms, stereotypes, and misinformation. An example of this would be a provider providing nutrition and exercise advice without asking, what do you actually do for nutrition? Tell me a little bit about your nutrition and overall movement patterns. Instead, they are making assumptions about someone's body shape or size, and those assumptions are then shifting the way that they are choosing to educate their patient. Also, when we think about educating patients and clients, we always need to ask for consent because we don't know their lived experience, we don't know their history, we don't know what they do or don't know. So it's really important to always ask and never make assumptions. With both of these types of bias, we can also start to see this, especially implicit bias, come across in body language, even again through the time spent with certain people in a client appointment. This can also be in direct or indirect client communication. So outwardly communicating that from an explicit fashion or even implicit. And even in the communication that we are, written communication that we are giving our clients and patients. So this could be even in the sense of diagnosis codes around obesity in the patient or in the things that they end up taking home. This can also be in a lot of the education, say it's around blood pressure. And a lot of times, if you look online for what do I do to manage my blood pressure, typically the first thing says lose weight, when inherently that is not a behavior that someone can actually act on. We also see this in interpersonal practitioner communication. So in notes that are shared in our office or in between clients or in between providers, as well as even in a more clinical setting in rounds. So one way to really think about addressing your biases is to, first and foremost, if you have a fat client coming in your office, we need to think about what would be my plan or treatment of care if this person was existing in a thin body. And then once you can ask yourself that question, we need to do that because every single body deserves the same access and respect around their healthcare and bodies later. Anecdotal bias is also really important to discuss because this is anecdotal bias or even confirmation bias. And so this is when a personal experience or a singular example is used to support an argument or position instead of actually looking at compelling evidence-based research. This can lead to clinicians making decisions based on their experiences or their experiences with previous clients or patients. And an example of this would be that a client comes in and they say they've tried weight loss multiple times and nothing has worked, but because a provider has maybe either done, say, for example, a ketogenic diet or has had one client who's done really well with that, or they've personally done really well with that, big air quotes around that, they are then going to assume that this is going to work for every person. We can also flip that and think this is huge, especially within a more clinical setting or an emergency care setting where people will come in and say they're existing in a fat body and they will go through their overall health history and maybe they have type 2 diabetes, maybe they have other chronic health conditions. And what they're going to then assume is that, okay, everyone in a fat body is also going to have X, Y, and Z. which isn't true. There are many people who exist in fat bodies who have no chronic health conditions, and that is not necessarily being in a body of size does not indicate that you're going to end up with a chronic disease, but because it's in this extreme setting, say, again, emergency department, they may end up seeing this more frequently because of basically just our kind of lack of overall medical care or people who have delayed care because they didn't feel respected overall. So, how did we get here? This is a very long conversation. This could be an entire hour-long presentation and or entire book. Sabrina Strings is a sociologist and wrote an amazing book called Fearing the Black Body, which investigates where a lot of the internalized anti-fat bias comes from. And it also comes from and is rooted in basically the racial biases that were very prevalent and are still prevalent, but very prevalent during the slave trade. So back in the 18th century, Black and fat bodies were thought to be impure, gluttonous, and overindulgent, and even hedonist. In the 19th century, we started to move into more of the eugenics movement, which was trying to find the ideal and or perfect human and try to understand which human traits were undesirable. And they found through this that Chinese and Jewish people, for instance, were thought to be prone to mental racial obesity, aka just by existing with the genes that they had, that they were more likely to be obese or exist in a fat body. Through the eugenics movement, they also started to create standard weight tables, which argued that fatness was a constitutional flaw. And if you did have an extreme amount of fatness on your body or existed in a larger body, that also meant that you were flawed as a human. So we start to see this aspect of from the 18th century and 19th century of morality being deeply embedded with health and body size. Also in the 19th century, Adolphe Quetelet was a Belgian astronomer, and he was the first one who actually invented the BMI equation. It was first referred to as the Quetelet index, and he created this math equation, which is basically just a ratio of overall height and weight. And he wanted to see if there were any correlations that he could come up with this ratio number, correlations with health or anything else in his population. And we need to recognize that his population was a population of white men only. And he specifically stated that this was not meant to be used as an individual medical assessment tool. Then in the 20th century, Ansel Keys, who was a prevalent researcher, used the Quetelet equation and started to refer to it as the body mass index scale. And he used this equation in his research and also noted that it shouldn't be used on an individual level because he found that BMI wasn't a predictor of overall health or disease. And there's a little hitch here is that he still declared the metric as a success because it was easy to calculate, unlike other standard weight tables. And because this equation was originally invented again in the population of white men, which we have now expanded to use across all ethnicities, all genders, we can know that this is inherently flawed because when we start to expand this out to a more diverse community, that number and predictability of this equation statistically is going to be less accurate. And then in the 70s, when healthcare and health insurance became more prevalent to be provided by your employer, the NIH and the USDA started to create desirable weight tables for men and women. And these were also based on white men and women. They then dropped those tables and then shifted just to using BMI, again, because it was quick and efficient. And in the 1998, the US had our own standard definition of what underweight, normal weight, overweight, obese, and morbid obesity were categorized as. And that was different from the WHO guidelines. And so in 1998, the US adopted the WHO guidelines, and all of the sudden, Americans woke up the next day and often were shifted into a different category. And now many people were automatically overweight overnight or obese overnight. And so this is where some of this comes from. A lot of this is also rooted in a lot of puritanical culture, in this, and rooted in white supremacy and trying to other bodies. The othering of bodies from creating this class-based system, and using this as a way to create easy, quick judgments. So, because we know, hopefully now, that BMI is not a great measurement, the last year, the American Medical Association also agreed. They released a statement stating that BMI was an imperfect measure for assessing individual health and it should not be used as a sole indicator for clinical decisions. They recognize that BMI does not account for factors such as muscle mass, bone density, overall body fat distribution, and racial or ethnic differences, which can all significantly impact health outcomes. And because BMI is just a height and weight ratio, it doesn't differentiate between lean tissue versus adipose tissue. And health outcomes associated with specific BMI can vary significantly based on individual factors such as race, age, gender, physical fitness. And there's this term called the obesity paradox, which actually shows that people who are in an overweight category may live longer because actually having a little bit more weight on your body can be more protective, especially as we get into our upper years. So many people ask, if we aren't using BMI, what do we do instead? Well, we use our heads. And they're now recommending that there should be specific metrics that include body adiposity, relative fat mass, waist to hip ratio, and waist circumference. And that BMI should never be used as a classification for overall disease and or the assumption of health. So, what happens if someone experiences anti fat bias? Well, there's a 60% increase in mortality risk when you control for other factors, such as physical activity, gender, race, nutrition, smoking, alcohol intake, so many things. So, basically, there's 60% increase in mortality if someone has experienced weight based discrimination. And it is well documented in the research that the medical field, and in a medical setting is where the most weight-based discrimination exists, which results in patients delaying essential medical care, also results in poor patient client provider rapport, and can negatively impact health markers and outcomes for years to come. Medical students, physical therapy students, even nutrition and dietetic students, have very, very high rates of anti-fat bias when they start to examine it in the research, and also have a lot of negative judgments and stereotypes towards people who exist in fat bodies. So with physical therapy students, this was a study, and they characterized people who were quote unquote obese as lazy. And over 40% of the US adult population report experiencing weight stigma at some point in their lives. Doctors also spend less time with obese patients compared to their quote unquote thin patients. And you can see the numbers below. And when looking at this, it's been very clear, especially in the last 5 to 10 years, that racial trauma and oppression have negative health outcomes. And I beg of you to consider that this is the same thing that is happening if someone is experiencing weight based discrimination. We also need to recognize that discrimination based on gender, age, religion, or ethnicity, and disability is illegal. Yet, Michigan is the only state in the country with a law banning fat and body size discrimination. And it has made height and weight protected classes in the state civil rights law. And this was a fascinating notion that was spearheaded by their own medical students at Michigan State University. And because of this, Michigan delegation to the American Medical Association, they sent delegation and made a statement saying that they are acknowledging that weight stigma and social determinants of health are key factors in the outcomes of someone's long-term health, longevity, and well-being. So I beg of you for a moment, based on your knowledge and experience, what are some of the reported negative health outcomes for those with obesity? And as you reflect on this, you may be having some assumptions in your head where, or based on things you've heard in the media that are around being quote unquote obese puts you at a higher risk for chronic disease, mental health disorders, and overall mortality. And let's dive into a little bit of research on that assumption. If we take a moment to consider all of the conditions that are associated with obesity, so poor sleep, mental health disorders, chronic disease, disordered eating, eating disorders, physical inactivity, I could go on forever. These are also all of the same conditions that are negatively impacted by someone who has experienced anti-fat bias or weight stigma. This is a 2016 review that was showing what happens when someone experiences weight stigma when seeking care for diabetes. And what they found was that if someone experienced weight stigma, they had an overall increased allostatic load, so increase in overall stress on the body, which will negatively impact the hypothalamus pituitary axis and result in an increase in stress hormones such as cortisol, epinephrine, norepinephrine, all these different things. It'll also increase overall C-reactive protein, so one of the markers of inflammation, and it'll start to increase. Well, one thing that cortisol does is it will start to mobilize more sugar from the liver, and it will also decrease insulin sensitivity, therefore increasing someone's overall blood sugar levels and A1C. So that's what's happening from a physiological level. From a behavioral level, what's happening is that oftentimes people who experience weight stigma have higher rates of binge eating, have increased caloric consumption, have maladaptive weight control behaviors, meaning yo-yo dieting or cyclical dieting, disordered eating, as well as lower motivation to exercise. A lot of this is because many people don't feel safe in a fitness or gym setting because of fear of further stigma and bias, which is going to result in overall less physical activity. So what do these things do together from the physiological level and the behavioral level? These will result in overall weight gain. And then from the healthcare service standpoint, there's going to be overall poor adherence to treatment. So from a client level, a lot of this is because of that overall bias that they're experiencing. They may not trust their doctors or their providers. There's going to be a delay or even lack of care or follow-up care, which is going to then result in possibly certain conditions going undetected and undiagnosed for years, resulting in possibly higher rates of cancer, resulting in higher rates of type 2 diabetes, and resulting in higher rates of high blood pressure, cardiovascular disease, because there isn't this routine medical check-in. And so, because of all of these things, along with the societal weight stigma, we are going to start to see higher rates of anxiety, depression, low self esteem, poor body image, substance use disorders, and suicidality. And because of either a lack of access to care and also decreased motivation, because these clients are often not getting actual behavioral based modifications that they can intervene on, there's going to be less effective overall self care and self management of possible chronic diseases. And then the cycle continues. And then when you start to look at this 2019 observational study, this had 3,609 British adults included in this study. And they found that the indirect effect of weight discrimination could account for 20% of the total effects of quote unquote obesity on longitudinal changes in physiological dysregulation. Very fancy science speak for saying if someone has experienced weight bias, they are 27% more likely to have physiological changes and dysregulation, meaning higher blood sugars, elevated blood pressure, altered fat and lipid values, just because of the way that they are perceived by society at large. And this is often a conversation when it comes to weight neutral or weight inclusive care is where's the research? Where's the data? And we need to understand that all of and most of the overall weight loss research and evidence that we have is inherently biased. There are billions and billions of dollars of funding that is funneled to the study of weight loss, obesity, and weight management research, while there's only 2 million allocated towards studying weight inclusive care, weight stigma, and bias. So therefore, if we have this disproportionate amount of research coming from this weight management and anti-fat bias space with this lens, it is going to be very hard to start to counter that with research if there's not enough funding for it. So when someone is saying that weight loss is evidence-based medicine, we need to understand it's inherently biased because there isn't an opportunity to have a weight neutral research conducted, because who's going to fund it? We also need to note that there is an extreme amount of money in weight loss from drugs, diets, gyms. Yes, I'm a gym owner, but that's a different conversation. And supplements, and these are a massive, massive market. And there's unfortunately not a lot of money in respectfully treating clients and patients and humans around us. Outside of the research setting, we also have a lack of medical equipment that's appropriate for all body sizes. So, meaning imaging, treatment tables, surgical equipment. That means intubation tubes. That also means even the training of anesthesiologists. Typically, there's BMI cutoffs for surgeries because of a lack of awareness and education on how to actually anesthetize a body of size. So let's take another moment to reflect. So, a little bit of food for thought. Is it the weight that is causing poor health outcomes, or is it the systemic effects of research, medical, and societal weight bias? So, hopefully, you have a better understanding that there is a massive gap in how we are treating bodies, where our research and even data comes from, and how this goes so far back through our history, even as a country, but also as a society at large. So, I want to dive into even the fact of diet culture, beauty culture, and wellness culture. And so, what diet culture is and beauty culture and wellness culture is a societal belief system that upholds the thin ideal and directly correlates body size and shape with health, morality, and self discipline. It is a culture that promotes a narrow standard of beauty while stigmatizing those who don't conform to these ideals, and it perpetuates a culture of consumerism, ageism, racism, ableism, and propagates misconceptions about food and exercise. It does this all the while ignoring the role that genetics, trauma, systemic oppression, and social determinants of health have on our overall health as humans and individuals. So, today, the overall diet industrial complex and wellness industrial complex is worth over $75 billion. And in 2022, over $75 billion, and this is rapidly increasing as the years go on, were spent on diet programs, slimming facilities, meal replacements, and weight loss supplements. And nearly 50% of the US adult population has reported trying to lose weight from 2013 to 2016. And again, this data is a little bit older, but in the wake and environment of overall weight loss medications, this is also dramatically increasing. And as we start to see weight loss attempts increase, we also start to see obesity rates start to increase and weight based discrimination increase in a very smooth, easy trajectory line. So, as medical providers and healthcare workers, we are ethically bound to do no harm. But if we are actively telling people that they need to lose weight and shrink their bodies, we need to also understand that this is causing harm, especially in the current wake of childhood quote unquote obesity. It's important to look at the fact that a child is 242 times more likely to have an eating disorder than type 2 diabetes. And eating disorders are the second deadliest mental health disorder, coming just right behind opioid use disorder. And then when we start to look at dieting, anyone can generally lose weight for a short period of time. But what ends up happening is once we stop doing unsustainable behaviors, typically that weight starts to come back. And so this is called yo-yo dieting or weight cycling. And what this does is this causes metabolic adaptations because the human body is engineered to survive. And if we continue to lose weight at a gradual rate forever, we would be dead. So that would be a pretty silly evolutionary flaw. Therefore, people can lose weight for a short period of time, which also ingrains this quick fix mentality. But because they oftentimes these behaviors, diets, or supplements are expensive and or unsustainable, what ends up happening is that because we have this metabolic adaptation, we have a decreased basal metabolic rate, we end up staying there for a little bit until our body feels safe enough again. So all of the sudden, if we have a decreased metabolic rate that was matching our overall decreased caloric intake, it will end up staying there. And once we go back to eating a whatever a normal amount is, all of a sudden the body could be then in a quote unquote surplus of however many calories. There was a fascinating study that looked at the contestants of The Biggest Loser, and they measured their basal metabolic rates before going and starting to enter this TV show, and then they looked at them and followed them later. Granted, it's a small study because there aren't that many contestants, but what they found was that their basal metabolic rate was drastically decreased, and they found that the longer they were in their maintenance phase, it was even more difficult for them to maintain that weight loss because their body, even through exercise and caloric restriction, was starting to continuously decrease that metabolic rate. So therefore, they ended up gaining weight back and gaining it at a higher rate. And many times people end up losing weight and end up regaining all the weight back. And oftentimes there's an overshoot where they end up gaining even more. This even starts to impact our endocrine system. So there ends up being hormonal imbalances. Anytime that we end up losing weight, we also end up losing muscle mass and bone density. And we end up, if we're restricting a significant amount of calories and nutrients, we end up with nutrient deficiencies, which are essential for overall the maintenance of all of our organs and all of our physiological function. And because of the decrease in muscle mass, we start to see increased risk of injuries and even delayed wound healing. Then we start to see the mental health impacts of this, and body dissatisfaction and self esteem. So, dieting is not benign. It is not something that is just an easy, flippant thing we need to be, that we should be prescribing to people because there is inherent risk and inherent harm. And much of this that I see in my clinical setting is something that lasts for years to come. And the first reflection question that I asked you was to think about the quote unquote health risks that are associated with obesity. And so many of these are what we can also refer to as metabolic syndrome. So that means increased blood pressure, low hip to weight ratio, elevated fasting blood sugars or glucose, elevated triglycerides, and low HDL lipid levels. And metabolic syndrome is not something that is just caused by someone's body size. It is a cluster of biochemical and physiological abnormalities associated with the development of cardiovascular disease, type 2 diabetes, and is often what we think of as when we think of the health risks of someone being quote unquote obese. And when we're starting to look at this as an overall diagnosis for this syndrome, we need to understand that we can't even agree on a specific criteria that has to be met in order to have this diagnosis. So up here, you can see different governing bodies and medical governing bodies from the International Diabetes Federation, the American Heart Association, and the National Cholesterol Education Program's Adult Treatment Panel. And when we look at this, so you either have to meet two to three of these specific criteria in order to be diagnosed with metabolic syndrome. And because it's two to three, based on the governing body, those criteria are going to be different. And we need to also note that BMI is in no way, shape, or form a risk factor for having metabolic syndrome. So this is a fascinating study that I think really represents and shows us the way that anti-fat bias affects all of us and how it negatively harms all of our health. This study went out to examine the mortality risk across weight categories with those who have metabolic syndrome versus those who do not. The study included data from the NHANES dataset from 1990 to 2010 with over 12,000 US adults. And what did they find? They broke the categories up in those who were normal weight with metabolic syndrome versus without it, overweight with metabolic syndrome versus those without it, and obese with metabolic syndrome and those without it. And they found that those who were overweight with metabolic syndrome had a lower mortality rate than those who were normal weight without metabolic syndrome. So basically those who didn't have metabolic syndrome that were overweight had a lower mortality rate, died at lower rates than those who were in a normal weight category. Need to note that there was a higher prevalency of metabolic syndrome in overweight and obese groups, but the overall mortality risk, so the risk of someone dying due to this, was much higher in those who are in a normal weight category when compared to those who are in an overweight or obese category. So when we look at the overall number of deaths, it was actually lowest in the obese group that didn't have metabolic syndrome. And the group that had the highest mortality risk was the one that was in a normal weight group with metabolic syndrome. We need to note that this study did not control for someone experiencing weight stigma or anti-fat bias. And I think the biggest take home of this is I find that in a lot of my clinical practice, there are individuals who come in who are in a straight size body, so a thin body, and maybe have all of these markers in the sense of elevated lipid labs, elevated blood sugar levels, and even elevated blood pressure, but because they don't exist in a fat body or a body of size, their doctors are often saying, oh, it's just a little bit of that, it's just a little bit of this, it's okay. So that's where this implicit bias starts to come in. And so we are basically not giving adequate care to those who exist in a normal weight category because of this internal bias around the risks of existing in a fat body. So I think it's really important to note that disease and chronic disease can exist across the size spectrum, and it is not at all related to specific weight. So from a clinical setting, we need to be screening every single client and patient who walks through the door for any sort of chronic health condition, and we need to take them just as seriously as we would with someone who exists in a larger body. And for those who exist in a larger body, we need to take their concerns just as serious as someone who's existing in a smaller body. So I've talked a little bit about weight cycling and yo-yo dieting and the negative health effects of that, which we'll dive into a little bit more here. And we need to understand that first and foremost, dieting does not work. When we look at the timeframes of research studies for specific diets or specific weight loss management protocols, they typically end after about 3 years, and that's because their data ends up starting to get skewed and they're not seeing the outcomes that they want, so they end up ending the studies. And as I mentioned before, anyone can lose weight for a period of time, but what ends up happening over the next 2 to 5 years is that people end up gaining weight back and typically end up gaining more weight because of that metabolic compensation. So, what happens later? What are the actual effects of weight cycling or yo-yo dieting? This was a meta-analysis that was conducted in 2015 that reviewed the benefits of focusing on cardiorespiratory fitness versus intentional weight loss. And so they established this weight loss futile cycle. And so basically, there's this desire to lose weight, increase in weight loss attempts, a failure to reach that goal weight or maintain that weight loss, which resulted in increase in frustration, a decrease in adherence to the weight loss plan, which led to weight regain, often again that metabolic overshoot, which then also increased the overall prevalence of obesity. And I've talked about some of the negative effects of weight cycling from even a bone standpoint, a muscle mass standpoint, and sarcopenia, and even when you look at osteoporosis. We also need to know that the most important and essential things in our body are our organs. Our organs and our muscles are the two things that utilize the most caloric energy. And when we end up decreasing our overall caloric energy intake, we end up also decreasing our overall organ function. And what this does when our organs aren't functioning as well and we have muscle loss and bone loss, this will start to increase inflammatory markers, which will often negatively impact osteoporosis or osteoarthritis, which is something that is often associated with people in larger bodies, when in reality, osteoarthritis is an inflammatory condition that exists people across the size spectrum, just like every other condition. And when we have this increase in inflammation, we also need essential nutrients in our bodies from not only calories, but also vitamins and minerals to help combat that. And so when we don't have those, this cycle starts to continue. Overall, when people end up yo-yo dieting or weight cycling, there's also a decrease of participation in physical activity and motivation too. Again, this comes from a very biased standpoint because people feel like they don't fit in, they fear judgment, they fear that they will be discriminated against, so they just don't end up doing it. There's a lot of fear around even just walking outside in the neighborhood and having people be feared of judgment of what are people going to think when cars are driving by or other people walking by. And so weight cycling overall is, along with weight stigma, is associated with a higher all-cause mortality rate, increased rates of cardiovascular disease, and overall decreased muscle function. So in this study, they looked at the benefits again of physical activity and focusing and increasing cardiorespiratory fitness without a focus on weight loss. And what they found that when they did this, when they looked at, okay, can we move more? Can we increase the time that you're moving? Can we increase the intensity that you're moving without focusing on weight loss at all? And what they found was that when they did this, the association between weight and BMI and mortality completely disappeared. With this, they also saw an improvement in every single cardiometabolic marker independent of weight loss, which meant blood pressure, cholesterol, triglycerides, blood glucose. And if there was weight loss, it was noted that it was a side effect of their training and physical activity, but it was not intentional. And because of this, what it was that it actually showed a decrease in overall visceral and abdominal fat, so fat that's existing around the organs, which can be more inflammatory and more harmful and increase the risk of metabolic syndrome. And exercise decreases visceral fat without even having any other dietary interventions. So, if we can instead not focus on weight loss, but really start to focus on behaviors that are going to be health promoting for individuals without a weight goal, then we start to see the prevalence of weight cycling decrease and we start to see improved overall health markers. So, if weight doesn't impact our health, what does? Well, the social determinants of health definitely impact our overall health risk and health outcomes. And these are defined as non-medical factors that influence health outcomes. They include the conditions in which people are born, grow, work, live, and age. And they also include broader systems and forces that shape daily life. And the social determinants of health can affect a wide range of health, functioning, and quality of life outcomes and risks. It's been shown that 40% of health outcomes are actually based on our socioeconomic status, and there's a 76% higher cost in households that are food insecure. Also, when we look at oppression overall, those who experience any sort of racial trauma or oppression have a 31% higher risk of developing type 2 diabetes. And so we need to understand also, how does weight-based discrimination and bias negatively impact our social determinants of health? Because those are going to be the things that really start to matter. So when we look at overall education, we start to see lower test scores in those who have experienced weight bias and stigma. We have less economic stability because there's overall discrimination, but also discrimination in pay and hiring, because again, Michigan is the only state that has this as a legal protection. We also start to see a degradation of our social and communal health because there's social isolation, because of fear of judgment. Also, this is going to negatively impact our mental and emotional health outcomes. And then we start to also look at the healthcare and access to healthcare. So again, those who exist in larger fat bodies or those who have experienced any sort of anti-fat bias before or discrimination are less likely to seek medical care due to fear of more discrimination. So this is a wage gap study. While it's not a quote unquote scientific study, I found it really interesting to start to dive into. And if we start to look at the education and overall economic impact and how that's going to impact our overall health outcomes and social determinants of health, you would assume that someone who has a higher education would also have higher wages and better health outcomes. But because bias prevails again, we actually start to look at the data and see that those who have a higher state of overall education, they have upper level degrees, but also exist in fat bodies, actually earn less than their thin and or straight size body peers. And we start to see this actually increase, this wage gap start to increase as people's education levels also increase. So as usual, men will have a little bit higher wages than women, but we start to see this, especially when we start to get into the graduate degrees. Obese women are likely to earn 90% less than their straight size peers, and men are estimated to earn 14% less than their straight size peers. So, if a weight centric healthcare model decreases access, increases weight stigma and eating disorders, and worsens health markers, there should really be only one ethical and viable option for the future of healthcare. Oftentimes, as providers, we need to take a moment and get really clear on our goals and our desired outcomes and do this in conjunction with our clients. So we may have things that we want to change, but our clients and patients also need to be bought into this. So oftentimes it has been from this weight centric perspective where weight is going to be the thing that we are told impacts our blood sugars. It's going to impact the rates of sleep apnea. It may impact our overall mental health. It's going to impact our cholesterol levels, bone and joint health, self-esteem, liver function, blood pressure, all of these different things. But we need to remember that weight is not a behavior, and we need to start focusing on behaviors because those are the things that actually improve blood sugar levels, blood pressure, self-esteem, all of that. So for someone who's trying to manage their blood sugar levels, what are going to be the things that we do? We're probably going to look at their overall nutrition. We might look at their overall movement. We might look at their stress and their sleep behaviors. And all of these, again, are behaviors. And weight loss may be a side effect of these behaviors, but we need to understand that this cannot be the overall goal because someone cannot walk out of our offices and just go lose weight. But they can walk out of our offices and maybe start to incorporate more movement in their day or start to make some tiny shifts in how they're eating, which will directly impact their blood sugar levels. This is even kind of a bigger thought experiment when it comes to osteoarthritis. So, again, a lot of times people who exist in fat bodies will try to get their arthritis under control or even try to seek maybe a joint replacement surgery so that they can move more comfortably. What ends up happening is that there are BMI cutoffs for these surgeries, so people try to inherently lose weight to be able to be able to get the surgery and qualify for the surgery. And as we know now, what that ends up doing is this will increase their overall or decrease their overall muscle density and muscle function. It's also going to increase their or decrease their overall nutrient intake, which is also going to then, once they do get surgery, impact their overall risk of infection. It's going to delay wound healing. It's also going to delay overall recovery. And so we need to remember that when someone is having osteoarthritis or joint pain, it's not because of the weight on their body. Joints respond really, really well to weight, which is why strength training and supporting that joint is something that is very well documented in the research as an effective treatment for osteoarthritis as long as it's managed correctly. But if we are saying that weight is going to impact arthritis, why would we be loading the body with external weight through a strength training program? We wouldn't. So when you're telling someone to lose weight because of that, we can start to see that argument fall apart pretty quickly. So if we aren't looking at weight and using BMI, what are we going to do? We are going to look at other biometrics. And I want to note that weight is a metric that I do consider to an extent. And I really only consider it if it's fluctuating in one direction or another. If someone's rapidly losing weight, I'm deeply concerned. If someone's weight is changing rapidly in the other direction, I'm also concerned. So that's how I'm using it as a metric, but I'm not using it to determine someone's health. So I'm looking at their other biometrics such as blood pressure, their heart rate, their lab values. I'm looking at if they have access to their heart rate variability, and I'm looking at their cardiorespiratory fitness. What is their movement and engagement in movement and physical activity look like? What is their overall mental health status and their communal status? Meaning, what do their communities look like? What do their social relationships look like? Because we know that isolation and loneliness is also a major predictor of mortality. As clinicians, we can also start to screen for social determinants of health and ensure that people have access to food. So before you tell someone what to eat, we need to be asking them, what does your access to food look like? Do you have somewhere to cook? Do you have somewhere to store your food? Because if not, all of this is going to fall really flat. We also need to understand from a social determinants of health standpoint, does someone have a space that they can safely move outside? That ends up being a barrier for a lot of individuals, either from a traffic standpoint, lack of sidewalks, or even fear of, again, discrimination, or just overall personal safety fears. We also need to look at someone's genetic and family medical history because that can be a predictor as well of what are some things that are coming down in the future, possibly for this individual. So when I'm not looking at weight, these are all of the things that I'm looking at. And I'm also allowing my client or my patient to determine what is healthy for them and what does that look like, because it may not be related to all of these things. And so we can really start to make this individualized so that we are actually meeting their needs and not ours. So some principles of weight inclusive care, these are defined by the Health at Every Size principles, and these are recently updated to include 10 different principles. And the first principle is that health at every size approach or weight inclusive care is grounded in liberatory framework. So it is not a social justice movement in itself, but providers and practitioners who are working in this space are remaining committed to the ongoing learning and liberation from thought leaders in Black, Brown, and people in Black and Brown communities and people of color, those who are in the fat liberation space, those who are getting involved in disability justice, queer liberation, and intersectional feminism. Because when we are starting to look at liberatory frameworks, we need to understand that we can't just affect one group or one population, but we need to understand that justice is really justice for all. Second, we need to honor a patient's and a client's bodily autonomy, meaning that they have the right to choose how they proceed with the treatment plan after they're provided with all of the treatment plan options, and they are informed and aware of the known and possibly unknown risks and benefits of that treatment of care. When we start to then look at informed consent, so informed consent must include what we don't know as clinicians, as well as include what we do know. There are many fat phobic and healthist ideas that influence what we believe and that we believe is the best course of treatment. So we need to understand that we have our own inherent biases walking into many of these sessions and many of these appointments with their clients. And we need to be able to share the whole breadth of information and give people all of the risks and possible benefits of certain treatment plans that we are doing, as well as do this without our own inherent bias impacting it. So if I have a client who wants to come in and lose weight, and I am someone who is a weight inclusive provider, I am going to not tell them that they are bad or that they're a bad person for this. I'm going to listen to them. I'm going to also ask them what would be the risks and benefits for them that they would foresee. And I'm also likely going to share with them some of the risks of intentional dieting or weight loss, and also some of the possible benefits, which could mean social acceptance. It could be being able to buy clothes or fit in an airplane. So there are benefits. And so we need to, with our clients, sit down and really start to assess and make this an individualized plan and treatment plan for them. We also need to offer compassionate care, and we need to have a lot of humility, and we need to start to seek out stories and understand that our lived experience is going to be very different from everyone else who's walking in our doors. We need to really start to learn how to turn our ears on and start to open our eyes to the lived experience of others so that we can really provide that compassionate care. We also need to be able to understand research and use critical analysis tools. And we need to understand, again, that a lot of the research is going to be rooted in anti-fat bias and has played a profound role in shaping the medical research and recommendations that's widely used in our healthcare system today. The sixth principle is that providers must have the skills and equipment to provide compassionate and comprehensive care for people in fat bodies. We need to remember that only 1% of the entire medical profession is educated on how to care for those in fat bodies. So we need to learn how to educate ourselves and get the training that we need in order to provide that compassionate and comprehensive care. The seventh principle is our responsibilities. We have an ethical framework to guide our clients and patients in helping them understand how we can support them, and specifically from a harm reduction approach in this weight bias world. We also need to have the tools and be able to have conversations with our clients so that we can support their health goals, which are not our health goals, but their health goals without the pursuit of weight loss. We also need to take steps to examine our own internalized and externalized biases related to weight. And that's including not only with our clients, but also our community around us, other providers that we communicate with. Because if we don't do this, it is very likely that there will be some of that internalized bias that is going to come through in your body language, in the way that you're communicating, and in the education that you're providing. Lastly, as providers, we need to be engaged and committed to the ongoing work of addressing systemic anti-fat bias in our communities, in our workplaces, and with even among friends. Because if we can start to do this, then we are then creating safer and more equitable spaces for all bodies. So those are the 10 principles of a health at every size approach and weight inclusive care. And so when we do look at some of the evidence that we do have towards intuitive eating and or a more health at every size approach, we do have some great data. So intuitive eating is a framework that was developed by two dietitians in the mid 90s. And in short, it involves approaching food and movement choices from a place of self-care, permission, body acceptance, as opposed to a space of self-control, deprivation, and weight stigma. So in the study in 2014, what they found was that this was the weight inclusive, intuitive eating based workplace wellness program. And what they found that with a focus on weight inclusivity and focusing on intuitive eating behaviors, they found an improvement in overall diet quality, so more nutrient density overall. They also saw a reduction in weight stigma, which is also going to have other effects in that aspect of internalized weight stigma, which is going to impact outcomes from a mental and physical health. I also saw a significant reduction in the consumption of added sugars, fast food, and other sugar sweetened beverages, and a decrease in eating disorder symptoms and or behaviors. The middle study was looking at intuitive eating practices and how that impacted biomarkers from a cardiovascular disease standpoint. And they saw that with greater levels of intuitive eating, there was also lowered LDL levels, as well as, or a lower LDL and HDL ratio, so therefore lower LDL levels and lower triglycerides. And then when we look at this from a mental health standpoint, which I think is very important, we need to also see that those who practice a more intuitive eating and weight neutral framework and practices, they started to also see lower rates of depression. They started to see improved self-esteem and also decreased behaviors around unhealthy weight control, extreme dieting, and weight cycling. So when people say there isn't data around a more inclusive and weight neutral approach actually having a beneficial impact on health and physiological symptoms, we know that that is false. And again, there's a huge gap in funding. So hopefully in the next few years, we will start to see more and more of this come out. So how can we do better in the current climate that we're in? We can start off by getting curious and listening to our patients and our clients, and we need to also provide with appropriate screening. We need to address our own biases and ask ourselves, am I comfortable working with people in all bodies, shapes, and sizes? We need to ask ourselves, what biases and assumptions do we make about someone's character, intelligence, success, health status, or lifestyle based on their size? We also need to take a behavior-based approach when it comes to creating change and in the education that we're giving our clients and our patients that is independent of weight loss. And when we look at screening, I, for one, have never been screened for an eating disorder. I know that many of you probably have not either. And when we look at even the data on eating disorders, there's about 9% of the population that has a diagnosed eating disorder. But if we aren't actively screening for these, are we actually getting good data? And I would definitely argue that number is much higher. there's many screening tools that you can use. So you can use validated screening tools. But I would also say that you can also just be a human and ask questions. So one great question to ask is, do you mind sharing a little bit about your relationship with food? Another thing is you can just simply ask, whether it be on an intake form or in person, of, do you have a history of an eating disorder or disordered eating? And that screening can be enough because when we look at eating disorders, we typically have a very specific idea of what they look like. It's typically a very thin, emaciated body, but only 6% of those who struggle with an eating disorder are actually clinically underweight. We need to understand that the way that bodies exist and the way that we have evolved is that if we continue to lose weight forever, we would end up dying as a species. We talked about this earlier. So we need to remember that some bodies actually may end up gaining weight in response to severe restriction. We also need to be screening people for their overall access to uh, overall food and safe housing and safe water and outdoor spaces, so screening for those social determinants of health. And we can do some general questioning. We can ask them, do you have safe and affordable access to food? Do you have a place to cook? Do you have a place that you can refrigerate food and keep it safe? Do you have time to cook? We also need to ask about their safe and reliable housing and transportation and job security, because if someone doesn't have transportation, then they probably can't access groceries. If someone doesn't have safe housing, they're probably also not cooking. If someone doesn't have job security, it's very, very clear that they're unlikely to go out of their way to spend more money and finances on food as opposed to keeping the lights on, keeping the internet on, paying for their car payment. So food is actually always the first thing to go when someone is experiencing financial insecurity. We can also screen for adverse childhood experiences. There's a screening tool here on the screen that you can utilize. But again, we can also just start to get curious and ask questions. And adverse childhood experiences include experiencing some sort of trauma in your upbringing and early childhood life. So this could be physical, sexual, or emotional abuse. It could be emotional and physical neglect. It could be living with a family member who has substance use disorder, witnessing or experiencing domestic violence, separation from a loved one, divorce or incarceration of a loved one, racism and discrimination, and also violence within their community. And because of this, and because of the way that trauma impacts our body and overall stress levels and allostatic load, this is something that is going to directly impact future health outcomes. Then we need to also start to screen and look at other metrics of health. So what is someone's family medical history? What do their lab values look like? What is their blood pressure? What medications and supplements are they taking? Because again, going back to the metabolic syndrome study, if we aren't screening everyone for these, we are having overall bias care and providing bias care, and we aren't serving our patients and clients well. So, as practitioners, we need to note that there's inherently a power imbalance because many of our clients come to us asking and seeking for help, but we also need to be able to kind of level those scales a little bit more, and we need to ask our clients and allow them to give us explicit consent for the treatment plans and the behaviors and things that we start to engage in. And we also need to allow them to opt out of certain things. I always ask people of like, does this sound okay to you? Would this sound like an interesting thing that we could maybe start to integrate into your life? And I tell people they always have the option to say no to me because this is not about me. This is about them. So if they feel like something either doesn't meet their needs, doesn't feel like something that they can feel successful at, then it's something that we probably just need to shift and change to work and meet their needs. We also need to ask ourselves as clinicians is if someone is coming in a larger body, we need to ask ourselves, what would I do if my patient was in a straight size body or a thin body? And then we need to do that because we need to know that, again, weight is not a metric of health. It is not something that is going to be a huge factor in it. And we need to look at what are the overall behaviors that we can actually intervene on. It's very important to, if you do weigh in your practice, I don't really ever weigh in my clinical practice unless I need to for some very specific reason. But if so, I always ask for consent. I always tell them why I'm doing it. Maybe from an eating disorder perspective, it's a conversation that we have where we're going to do a blind weight, and this is just for my information. There may be some boundaries that we create around creating some specific ground rules where we can have a conversation if it gets gets beyond a certain range that we have agreed that is okay, and so we can have that conversation later. But we need to always ask for consent. Can I weigh you? We also need to always provide the option for a blind weight, and we always need to weigh in private. In most doctors' offices and clinicians or clinical spaces, there's a scale in the middle of the hallway. And that ends up being something that is very, very vulnerable for a lot of people. And so I would definitely recommend asking for consent if you have to weigh someone, and then always, always, always weighing in private. And it's very rare that we actually need to weigh someone unless it's a prescription dosing, which I don't do as a dietitian, but sometimes for specific dosing of things, we may want a weight for that. But outside of that, it's not going to be the most effective thing. And it's going to be something that someone inherently is likely going to feel shame and some guilt around. So we need to understand, what is the purpose of this? And if it's in your charting system where it requires it, you can also say patient declined, or you can say patient stated weight instead of having an actual measured weight. We also need to use information that is non-stigmatizing. We need to provide materials and health-based education that isn't weight-centric, but is again focusing more so on behaviors. And we also need to reduce our comments around food and body and create and attaching some sort of morality to either of those things. I talked about this a little bit of how we navigate the conversation of weight loss with clients. Many clients, again, there's this power imbalance, and many of them want to impress you or please you. And they often don't have the words to say, I want to improve my health or feel better, because our world is so weight centric that it's really challenging for people to really start to come up with different language or verbiage around what that would look like outside of weight loss. So if someone comes in, they say, I want to lose weight, I'm like, okay, what would be the outcomes of that? What would be the things you would hope to gain from that? Oftentimes it's, I would have more energy. I would maybe be able to keep up with my kids. I would be able to get up and down from the ground easier. I would decrease my fears and anxiety around developing type 2 diabetes. There's so many things that end up being coded for weight. And when we start to look at it, we can intervene on all of those things by maybe looking at movement practices, maybe looking at their overall health and nutrition practices. And we can look at their sleep health and hygiene. And all of those things are going to be things that are going to help improve their overall strength, improve their energy without actually changing any number on the scale. When we come to that informed consent conversation, we also need to really share with them the overall quote unquote success rate. So meaning that it's not the most sustainable thing. Most people can't sustain weight loss for an extended period of time. We need to inform them about the harms of weight cycling, weight regain, and also the metabolic adaptations to weight loss. We need to educate on the risks and possible benefits of pharmaceuticals, weight loss surgeries, along with medical adaptations to weight, because even with pharmaceuticals and bariatric surgery or weight loss surgeries, we still start to see a weight gain eventually, because again, our bodies are meant to survive. We also need to acknowledge the risk of possibly developing an eating disorder or disordered eating due to dieting. And then we also need to have a lot of compassion, especially if you don't exist in a large or a fat body, for the fact that someone might want to change their body for overall social acceptance and the need to fit in. When we look at overall the hierarchy of important human needs and essential human needs, one of those is validation and fitting in. So that can be a huge aspect of it. So there's a lot of things we can do, from working on body image and working on relationship to self, that can help improve that, again, without inherently changing the size and shape of their body. So this is a helpful just overall table that kind of looks at how do we have a size inclusive space, how do we start to target stigma, how do we have sustainable evidence-based care, and how do we really start to look at consent and make sure that our treatment plan is patient and client centered. Hopefully this was helpful. Hopefully it wasn't too much. If you have any questions or comments, feel free to reach out to me. And again, know that it's totally normal to have resistance and some friction around this topic because everything we've ever known or been told around health is that weight is going to impact our health, and our health is going to be impacted by our weight. So it's totally fair to have some questions around this because I'm probably questioning and starting to uh, shift your whole worldview of thinking, hopefully. So if you want to have a deeper conversation, reach out, and thank you so much for listening. And there's a significant amount of resources that were included in this. So I hope you have a great one, and thank you for being here.